So we use the diaphragm when we are respiring. There is a hole within it that allows the esophagus to pass through and join the stomach. Now, within that opening, that is where normally you have the LOS. So by its mere position, normally you have the hiatus also helping or augmenting the closure of the LOS. And therefore, the LOS maintaining its position within that gap is very important. It's very, very important because the moment it moves out, for example, if it moves up, then it means that the backing effect, the additional strength that the gap, that opening is contributing to the closure will be lost because it is no more there. And therefore, the job is only up to the LOS to do. We don't have that backing. At times, you can get some other part of the stomach also protruding through this gap and moving upwards, exposing the esophagus to easy contact of the stomach content. As I said, if you are supposed to stay here and you move to the next place, we call it hernia. So you can have brain herniation. You can have intestines herniation. So it's not only the intestines that will undergo herniation for you to go for hernia surgery. No, even brain. If you have increased intracranial pressure, what we fear is the brain herniation because that will kill you if it occurs. That is why we quickly take measures to reduce the increased ICP to avoid brain herniation. It's just movement from your natural position. Here too, you can get movement of structures, either the LOS moving upwards or even the fundus protruding through the hiatus and moving up, becoming almost part of the esophagus. Easily, its content can now move up part of the stomach above the hiatus. That is the most common. And the remaining three are all classified as paraesophageal, covering the remaining 5%. So here it is just part of the gastric fundus that will protrude through and then join. Then when you have a mixture of the first one and the second, we call it a mixed one. Then at times, other organs, even other than the stomach, will also protrude. So for example, you have the bowel or the pancreas also protruding through the hiatus, releasing their content easily to get to the esophagus. Then you have the fourth one. So these are the types of herniations, and all of them can contribute. The most common is the sliding one, and all of them can also contribute to the pathophysiology of GERD. Any queries before we get to the clinical presentations? Signs and symptoms. Signs and symptoms. Now, for signs and symptoms, we have three. The so-called typical. So those ones are consistent with gastroesophageal reflux disease. That one, if it happens, then we all know, oh, this is it. Then we have atypical. These ones are not consistent with GERD because it doesn't relate to issues concerning the esophagus, but rather other organs other than the esophagus. If some of these signs and symptoms happens, then we call them atypical. Then the alarming ones, very serious, then we know that we are in trouble. Those ones too are there. So the typical ones, we know that is consistent with esophageal problems. So you have issues like heartburn, hypersalivation, belching, regurgitations. These are common with esophageal issues. But when others begins to complain of asthma-like signs and symptoms, meanwhile, the thing is regurgitation that is causing that. It's not that typical of GERD. How can you have GERD and of the respiratory system? So why is it that regurgitation is leading to cough? That's atypical. Hoarseness of voice. Now your nice voice has changed. You are not even romantic anymore. You are not romantic. You call me Bobo, then I'm frightened. That your nice voice as a lady, the romantic voice is gone. Hoarseness. Then pharyngitis. The pharynx is not part of the esophagus. So why? You begin to have chest pains, something close to angina. Are we having heart issues? Then dental erosion, because you have repeated regurgitation to the extent that some of the content even gets into the mouth. And these are acidic. And the moment you have repeated exposure of your teeth to some of these agents, they can cause erosion of your teeth. These are not typical GERD signs and symptoms. And therefore, when they happen and the cause is regurgitation of stomach bowel content, we term them as atypical signs and symptoms. Then the dangerous ones, alarming, and therefore we must act fast with all efforts. So when individuals begins to have difficulty in swallowing, dysphagia, then it is dangerous. Some of them will even have pain when they decide to swallow. That is odynophagia, and the pain could be continuous. All the time they are complaining that they are having pains. Because of this, they can't even eat well. Then they begin to lose weight. Others can even complain that they feel like they are being choked, especially during swallowing. These are serious issues. And some of these may depict the beginning of Barrett's esophagus, esophageal strictures, or even adenocarcinomas, cancer of the esophagus. And some of these things happen. Not to forget bleeding, because you can get bleeding from esophagitis, especially when it affects blood vessels there. These are alarming signs and symptoms. Those that are not typical, it relates to other organs other than the esophagus. We call them atypical. And those that are typical, they are consistent with problems with the esophagus, we call them typical signs and symptoms of GERD. This is how GERD can present, either typical, atypical, or alarming. Now, sometimes,
Hello, Dr. Wabo.
yeah, hello.
Please, can you re-explain the Barrett esophagus again? I didn't get the beginning.
Okay, so Barrett esophagus, I think it was part of the first slide. Naturally, the esophagus is supposed to be lined with squamous epithelium, meant for protection. That is what squamous epithelial cells they do. Their duty is to protect. But the moment you get repeated exposure of this harmful agent, they can be eroded. And if you are not lucky and there is regeneration, you could get columnar cells replacing the squamous epithelium. And columnar cells don't give protective function. They have secretory functions. So when this happens, esophagus now being lined with columnar cells instead of squamous cancer of the esophagus. Are we okay?
Yes, please.
All right. Now, from the way those who suffer from GERD, they will describe it. If you are not lucky, you may even think that they are having cardiac issues, like myocardial infarction, that is ischemic heart disease. And therefore, it's very important that we try by using signs and symptoms to differentiate between ischemic heart issues and GERD. So, for example, typical of GERD, the patient will complain that there is pain, but it feels like burning. So, burning sensation. And this pain becomes worse on bending. You are bending. It means that you are moving more because of your posture. You bend, more and more of the stomach contents can be thrown up and then come into the esophagus. That is how come when they bend, then they complain that that pain becomes worse. So by way of posture, either you bend or you stoop or you lie down. Because of your position, you are moving more of the stomach content upwards into the esophagus, and it will make that burning sensation worse. That is typical of the esophagitis. But the pain from cardiac ischemia, normally described as what? Crushing or gripping. It doesn't get worse based on your position. No. So that is one clear difference. Ischemic heart pains would normally radiate. So this is typical of ischemic heart pains. They radiate to your neck, your back, your arm. But angina pains will not normally radiate. Even if it will radiate, it cannot get to as far as your back, your neck, and those areas. For reflux pains, it gets worse. With hot drinks or alcohol, you are having inflammation, erosion, wound there, and you are taking, if that hot drink passes there, it can worsen the pain because that hot drink is not having any contact with the heart, of course. But of course, angina pains will get worse with exercise. Exercise, you are increasing myocardial oxygen demand, in which case you are even lacking. You lack oxygen. Supply of oxygen to the myocardium is limited, and you are increasing demand, you only worsen the case. So the pain or the signs and symptoms in ischemic heart disease worsens with pain. If it is truly GERD, because it is coming from the GIT and you have acid in there, the moment you take antacid, you realize that you are relieved. Angina pains will not subside on taking antacids. No. If you swallow the antacid, it doesn't have any link. It will rather be relieved by taking agents that can open up the blood vessels and enhance blood supply to the myocardium. So, for example, either you rest to minimize oxygen demand, or you take the nitrates to cause vasodilation so that you have improved blood supply to the myocardium. Angina pains will come with extensive dyspnea. Yes, you may get GERD issues that will come with dyspnea, especially when you aspirate. And then some of the content gets into the respiratory system. But typical of angina pains, it comes with dyspnea. So these are some of the things. And therefore, when a patient presents with chest pains, you need to ask questions around this so that you can have a fair idea, at least, whether it is in relation to the heart or just the esophagus. Any issues? Any issues?
Yes, please. Can I ask a question?
Hello?
Hello?
Yeah, hello.
Yeah. Please, I want to ask that with epigastric pain, um, is it common in GERD than in PUD? Or so if a patient presents with epigastric pain, will you relate it more to the GERD or PUD?
Well, PUD would normally have that. But of course, GERD2 will present similar. But that one is normally above the epigastric region. That's why we say that there is chest pains. But typical of PUD is epigastric. So I would link it more, but that's just one clue. That's just one clue. You need to add more. So I would add more options to it so as to confirm. But if I'm to deal with only one, like epigastric, then I'll relate it more to PUD, more than relating it to GERD. GERD, chest region, so chest pains. Epigastric, PUD more. Of course, you add others to be able to confirm. Please, are you okay?
Yes, please.
All right. Now, let's look at general diagnosis. We are going to look at guidelines, recommendations. But before that, generally, how do we diagnose this condition? History is very important because we've been implicating food substances, drugs, lifestyle issues, and all those things, smoking, alcohol, drugs, food, and therefore history taking is very, very important. So clinical history, very important as drug history, as social history, as family history. We even said family line. So all those histories are very, very important to help us diagnose the condition. Then, of course, the gold standard diagnostic tool, endoscopy. Feely, you go in there into the esophagus, you try and find out whether there are inflammations or erosions. Mind you, we have endoscopic negative GERD. So it is not always that when you get intact esophagus, that is no problem with endoscopy. It doesn't mean that the person doesn't have GERD. You could have somebody with GERD, but no problem with the esophagus. And therefore, negative endoscopic findings does not rule out the presence of GERD. Please note it. It was part of the introduction. Then we can also do ambulatory reflux monitoring. Ambulatory, go about your normal activities whilst we monitor. Some people, it's very difficult to implicate their signs and symptoms to GERD. They are having the thing, but you are not seeing any form of distraction. You are not seeing any acid secret. Then it means that you need to monitor them over some period. So there are probes, pH probes that you insert into the esophagus, and then they go about their normal activities. So anytime that acid is reflux, the probe will pick it. And therefore, with that, you can what? Confirm that yes, their problems is coming from regurgitation. Then we have manometry. Manometry, of course, will determine how well the LOS is contracting. That is very important. So LOS sphincter tone or LOS pressure can be determined using manometry. If it is loose, the manometry will identify and tell us that we have a reduced LOX tone. Then we can fix it. So these are the things that we can do to effectively diagnose, starting all the way from histories to manometry. Now, let's start. Endoscopy, that's the preferred technique for assessing the mucosa of esophagitis. If there is Barrett esophagus, endoscopy will help you to see it. Any other complications, strictures, bleeding ulcers there with esophagus, you can see. As I said, we have endoscopic negative GERD, and therefore, once you don't see GERD, note that. We also have, remember, endoscopy is invasive. It's not friendly, it's invasive. We also have less invasive ones where patient will swallow the capsule. They put a probe on your chest and then you swallow the capsule. And as the capsule passes through your esophagus, it captures the images. So it's having almost the same principle as endoscopy, but this time we are not passing any tube. You are swallowing a capsule, carrying a camera to capture images as it passes through the esophagus. At the end of the day, you meet it at the anus, then you collect it as part of your feces. This is recent advancement, very cool. If you are in Ghana and you don't have it, then you don't have any other option than to go for them to pass through that tube down your esophagus. That is endoscopy. Then the ambulatory pH testing. So that one, it is performed by when they pass a pH tube through your nose into the esophagus and they put it 5 centimeters above the LOS. So as the name suggests, ambulatory, you go about your normal activities. Then from time to time, in case you get any regurgitations, the probe will record it. And when you visit the office, as in the clinic, the gastroenterologist will now remove the pH probe and then look at the readings and then confirm that, yes, all this time you've been suffering from GERD, but it wasn't so obvious. But the ambulatory probing has helped us to identify that, yes, it was it. Then further recent advancement, let's look at combined impedance and acid testing. This one can do 2 in 1. So it can measure both acid and non-acid reflux. So acid reflux, we are talking about the HCl from the stomach. Non-acid, they are acid, but we are saying non-acid. We are talking about bowel secretions, pancreatic secretions. So this machine, this method can measure and even tell us where the problem is coming from. It's coming from acid secretions from the stomach, or is it coming from elsewhere, or both? Combined impedance and acid testing can do that. Then we have tubeless method of acid monitoring. An example is the radio telemetric capsule. So the good advantage that we get from this one is that it can give us longer duration of monitoring. So that one, we are convinced that we've been able to monitor this thing for 48 hours. And of course, if it is regurgitation that is causing these patient signs and symptoms, we can confidently say. So that is one advantage of this method. 48-hour monitoring. It offers 48-hour monitoring so that we can confidently confirm. Another technique is to do a trial of PPIs. So empiric use of standard stroke double dose PPIs. If indeed you are saying that it is GERD, then it is regurgitation coming from the stomach. Fine. We know that if you are able to reduce acid secretion, then the person in this case should feel better. So we can also try the use of PPIs that can effectively reduce the harshness of the refluxate. And therefore, if after 8 weeks of trying PPIs at either standard dose or double dose, and the patient comes back and says that, yes, I'm feeling fine after you putting me on this regimen, then we can suspect GERD. So the person comes in, heartburns, I'm having problems. Okay, go and take omeprazole. 8 weeks time, come back. The person comes back and he says, no, it's no more there. Then you know that, yes, it could be what? The gastric secretions that was highly concentrated in terms of acidity. And therefore, the PPI has been able to reduce the acidity. And that is why the person is no more feeling those problems. You can use this method to also diagnose. That is the empiric trial, normally 8 to 12 weeks. That is what we do. Then the esophageal manometry, we assess the function of the LOS, how well it is contracting, how well peristalsis is going on within the GIT. Remember, if the LOS doesn't contract, it opens. If any aspect of the GIT doesn't undergo peristalsis, pressure builds up. For example, in gastroparesis, a common problem with type 2 diabetes is a neuropathic issue. So they get it, and therefore they don't have enough peristalsis anymore. Gastric emptying becomes a problem. They are always bloated. They are having constipations, GERD issues. So the manometer or the manometry will help us to identify contractile problems, be it LOS contraction or not contracting, or any part of the upper GIT not also undergoing peristalsis, like antral motility failure. The manometry will help us to identify. So these are some of the strategies that can be used. Having said that, let's look at what the authorities are saying using the American College of Gastroenterology, their recommendations. Let's look at what they are recommending by way of diagnosis. Before that, is there any question? Any question before we continue? All right, then let's.
Hello.
Yeah, hello.
Please, can you go over the PureCam method?
Yeah, so PureCam SO, you are having a capsule with a camera embedded in it. So as if you are swallowing amoxicillin capsule, not knowing that it contains a camera. So as it passes through the esophagus, there is a detector that will be placed on your chest. So as the capsule with the camera takes the pictures in there, then it will be picked by that detector. Then the capsule passes through, it meets down there, your feces. So it's doing almost the same work as endoscopy, just that this one, it is less invasive. With endoscopy, we are pushing some tube down the esophagus, uncomfortable. This one is as if you have swallowed a medicine, but it is doing the job of the endoscopy. That's the only difference. Are you okay? Are you okay, please? The one who asked the question. Hello? Can we continue? All right. So let's look at individuals with classic, that's typical GERD symptoms. What the ACG they are saying. So they are saying that while they present signs and symptoms of GERD, belching, hypersalivation, heartburns, and those things, if you don't have any alarming signs and symptoms, there are no bleeding, no odynophagia, nothing of that sort, then we can do the 8-week trial with PPIs. That is when after 8 weeks, then you come and tell us you have improved, then we can implicate GERD, because the PPI has been able to reduce the acidic content. And for that matter, even if it's regurgitated into the esophagus, it's not able to give the classical signs and symptoms of GERD. So we can do that. But attempt to discontinue the PPI in patients whose classic signs and symptoms, they respond after the 8 weeks trial. So this one, you are diagnosing, but in a way, it's also managing. So 2-in-1. But do this. Perform endoscopy after a PPI trial or after you have stopped the PPI and the person problems bounces back or the person did not respond to PPI treatment. In that case, follow up with endoscopy. So you've done your PPI trial, the person did not respond, still complaining, or it stopped, but after you stopping the PPI, 2 to 4 weeks time, everything comes back. In that case, it may be some serious issue. So the ACG are saying that in that case, perform endoscopy to find out what is wrong there. Is there an erosive esophagitis? Do we have Barrett esophagus? Do we have adenocarcinoma? Do we have any wound there? Whatever. Go in there and see the thing for yourself. Now, if patient complains chest pain, but without heartburns, and if you have adequately ruled out the presence of any heart issues, I repeat, the person complains of chest pains without heartburns. At the same time, you have done the necessary labs to rule out heart issues. Which heart issues am I talking about? Ischemic heart issues. Class captain, how do you confirm or rule out ischemic heart disease? When I say class captain, I'm actually not referring to you, but you and your colleagues. Let me try and then get some names. This topic, you have done it over and over. So how do you confirm ischemic heart disease? For example, MI. Let me get some names here. No, I won't call Josephine again. Efia, how do you confirm or rule out? Hello?
Hello, sir.
Yes. So if you're on the call, how do you confirm ischemic heart diseases? Which labs would you recommend? You let me even make it this way. If you are pushed to the wall and I say, give me 3 labs that you would perform to be able to confirm the presence of ischemic heart disease like MI, which labs would you confirm and would you do? If you are you there, unmute and give us confirmation of ischemic heart disease like MI. Which 3 labs would you recommend? Anybody on the call? Confirmation of ischemic heart disease.
I think you do ECG and biochemistry, the troponins and those ones.
And so definitely I would ask you why ECG, why those biochemistries? Why would you have a lot of labs? So why are you mentioning this? So meaning you always need to justify your answers. Why would you want to do ECG? You only mention echo. You didn't mention sphygmomanometry. But straight away you said you would do ECG, you would do biochemistry. You started mentioning troponin. Why? Why those ones in ischemic heart disease? Is there any link? Is there any link that those labs can help you confirm? Why are you doing that? The one who just, as in, please, if you are there, continue. Hello? All right. So don't worry, you will do this. Am I online? Can you hear me?
Please, sir, we can hear you.
Okay. So you are going to do this with Dr. Takra. So let's continue. So if the person complains of chest pain, but without heartburn, and you have adequately ruled out the presence of ischemic heart disease, like angina, MIs, whatever, then they are saying that endoscopy or reflux monitoring is what we need to do. These two are what we call objective test for GERD. Those ones, they are objective. Once you do it and you get the results and it's positive, it's positive. It's not subjective that you can argue. So those with chest pains, without heartburns, you have ruled out heart disease. Please go in there and do endoscopy. Plus reflux disease, if you can do. They recommend against the use of barium swallow. They don't want people to do that. You can for this. The gold standard. We've been hearing endoscopy all through. So endoscopy is recommended as the first test. Hello.
Yeah, please. The barium swallow is it or for the entire conditions
Forget.
related to the G.
Forget. Don't do it.
But for PUD, you do it.
PUD, we didn't even mention get. It's similar to just that the difference in position. So guideline doesn't recommend barium to in PUD now. The two are almost the same, just that this one is happening in the esophagus. Everything about them the same. Yes. All right.
So when is
Then do
barium in the
ovarian maybe other issues. If maybe you want to check for other conditions, other forms of causes of erosions, or maybe you want to identify the presence of some deformities not relating to GERD or no acid issues, then fine. And that one, you are not going to do endoscopy. It's barium plus X-ray that you do. With these two, we want to go in there and see the thing feely. We are not using anything standing outside the body. Then we try and then paint the walls and try and see something. No, we don't want that. We want to see the thing. Because we are talking about issues like possibility of cancers, sores, bleeding, whatever. You get it. If you have the means to go to the battlefield, why do you stand somewhere and be reporting? Go in there and report. Are you okay? You will see things better. Please, are you okay?
Yes, sir. I'm fine.
Oh, all right. Okay. All right. So individuals too who complains of the alarming signs and symptoms, serious issue, do endoscopy. That's not the time to be doing trials of PPIs. No. Serious issue now. So please choose the gold standard. So alarming issues, choose endoscopy. Chest pain is difficult, it's dangerous. Rule out heart issues, do endoscopy. Plus, if possible, reflux monitoring. All right. Then patients for whom the diagnosis of GERD is suspected, but not clear, and endoscopy shows no objective evidence. That is the endoscopic negative GERD. Endoscopic negative GERD. It's recommended that reflux monitoring is performed because you are not sure. The thing is there, but you did endoscopy and it was fine. Everything is intact. Could they still be due to GERD? You are wondering. Monitor the thing for some time and see if you can get regurgitations over that period. Are you doing the 48-hour monitoring or less than that? Monitor. If you monitor and the probe is able to give you some positive readings, then you can still implicate GERD. Now, reflux monitoring, off therapy. So at times the patient may be on PPIs whilst doing the continuous monitoring, or others may also not be on PPI whilst doing the continuous monitoring. But we have the way that we grade the severity of esophagitis. We have the way we grade the severity of esophagitis. If somebody comes with high severity of esophagitis, according to the Los Angeles classifications, that is class C or D, then we are saying that do the monitoring without the person taking PPIs. Do the continuous monitoring without the person taking the PPIs. If the person takes the PPI, it reduces the acidity and it makes the severity becomes lower than it is. You want to expose the patient and try to find out how severe the thing is. So we are trying to confirm and to also determine the severity. So don't bring in anything that will slow down the severity. We want to be sure and find out if the thing is severe or not. So take off the PPI, do your monitoring. Let's see if it is GERD that is giving rise to Los Angeles classification C or D. What is this? This Los Angeles classifications. So this is a tool that is used to classify how severe an esophagitis is, graded from A to D. As you move from A to D, then the severity increases. How is this done? How is this done? So, of course, on endoscopy, you go in there and then visualize. What do you see? So what you report, you use it to grade. So if your findings determines that, for example, grade A, That is the least severe among the four. One or more mucosal breaks, which is less than 5 millimeters, and it doesn't extend between the tops of two mucosal folds. So as you can see, let me enlarge this thing. Yeah. So you can see A, B, C, D. Severity as you go from A to D. You can see the folds, 1 fold, 2 folds, 3 folds. Yeah. And they are saying that if per your results, you realize that yes, there is an injury, at least 1 or 2 injuries, but the depth or the length doesn't go more than 5 millimeters. It doesn't go more than 5 millimeters. Then it is grade A. If you find a similar thing, but the depth or the length is more than 5 millimeters, but you are not getting the wound linking up or coming across foods, as you are seeing here. Here you can see that this wound is linking up with another, linking up with another. So they are independent, but the depth is longer than as compared to the first one. So the first one will always be below 5 millimeters. Grade B, almost the same as grade A, but the depth is longer, more than 5 millimeters. It doesn't link up and then cross to other foods. Grade C, you have more than 5 millimeters depth, but they are linking up. So the wounds are linking up. But the good thing is that they don't cover more than 75% of the lumen of the esophagus where it is happening. The wound doesn't extend across more than 75%. Then the last one, the worst among all, you have deep wounds, and they cover more than 75% of the circumference of the esophagus. That is the worst possible esophagitis that you can have. If please, you have to do reflux monitoring. Of course, endoscopy will first review that, then add reflux monitoring to find out if, especially when you cannot see or determine if the reflux is what is causing that, then you have to do reflux monitoring in addition to the endoscopy revealing these classifications. All right. Now, how do we manage? How do we manage if you have confirmed you are, but you are sure that it is GERD? How do you manage? How do you manage? Don't forget the severe situations, but GERD has been or eliminate the signs and symptoms of hypersalivation, belching, chest pains, and what have you. We want to remove all those things. Then we also want to decrease the frequency or the recurrence or the duration of the reflux. We want to avoid that. If there are any damages, we would want to promote healing and, of course, prevent the occurrence of complications like Barrett's esophagus, odynophagia, dysphagia, cancers, and what have you. We don't want those things to occur, and therefore we are going to manage appropriately. Treatment strategies will include the following. So all the pathophysiologies that we discussed, we can now antagonize them, moving from hiatal hernia to lower esophageal sphincter tone being reduced, decreasing abdominal pressure, decreasing the concentration of the refluxit, trying to decrease contact time, trying to enhance the defense mechanisms of the esophagus. These are the strategies that we are going to use because they are the cause of GERD. So we want to decrease the acidity of the refluxit, of course. If it's less acidic, it can come into contact with the esophagus, but it may not be able to cause harm. We want to decrease the gastric volume available to be reflux. Yes, This can be done by improving gastric emptying, and of course, reducing the size of your meal. You have to do that. You want to improve gastric emptying and then increase LOS sphincter pressure. You want to improve the contractility of the LOS so that it becomes competent and will be able to close firmly to avoid backflow. You want to do that. You want to enhance esophageal acid clearance. If the acid comes into contact, are we having enough peristalsis? Are we swallowing enough saliva? Are we doing that? By way of our posture, are we able to use gravity to sweep the thing down? We can do that because these are all implicated as part of the pathophysiologies. Are we able to enhance mucosal protection, mucus production? Do we have anything that can work just like mucus, sucralfate, and the rest? We can employ all those strategies to improve. So in a way, you realize that the management is getting very close to that of PUD. The only thing that is not here is the factor of H. pylori. We have not implicated any infectious agent here. And for that matter, looking at the strategies, we don't have any chemotherapies here. We don't have any antibiotics here. But all the other strategies that are used in the management of peptic ulcer disease can be seen here. That's why I say that the two are almost the same. It's just that one is happening within the esophagus and the other is happening either in the stomach or the duodenum. Any queries? Any queries? Let's look at non-pharmacological strategies. Yes, you guys are pharmacists, so you are always in a hurry to pounce on medicines. But before that, let's look at other means other than drugs. So lifestyle modifications. Remember, we've implicated so many lifestyle issues. Lucky for us, some of them are modifiable, and therefore we can attack them. So you can stop smoking. Stop smoking. You don't have any chance to reduce it. Stop. Don't go there. Alcohol can be reduced. Alcohol can be reduced, except in severe liver disease or liver disease that you have to stop. In almost all the other conditions, alcohol is not about ceasing. It's about reducing it and taking it in moderation. You take like 1 unit, maximum 2 units per day. That will be fine. Just convert the units to volumes, depending on the strength of the alcohol that you are taking. Then you are good to go. If you eat very late, 30 minutes before bed, you are eating now, that time now you are sleeping. And the fact with kosua and ketchup and yes, you go there, you buy fried rice, you tell the seller, oh, you are a family of 3. Meanwhile, you are lying. It's only you. You get back home, you add all the 3 together, then you eat everything, heavy load. Just 30 minutes, 1 hour later, you are sleeping. Fat plus heavy meal. You are increasing abdominal pressure. The fat is relaxing the LOS. Your posture, you are lying down because you are on the bed. Independent risk factors, of course, you get the GERD. So look at all these possible lifestyle modifications. If you're on any drug that can contribute to GERD, and it's possible that avoiding GERD, do it. So if you're on dihydropyridine, calcium channel blocker, and you can switch to an ACEI or ARB, fine. If you're on bisphosphonate and you can switch to maybe a hormonal therapy or any other issue, fine, do it. If you're on any drug that can irritate you, please, if there are options, do it. If you're on any food substances, spicy foods, you take too much tomatoes, pepper, boys, you go to Akuzi Pub, then you add more ginger. You have been given the soup plus the fufu. Then you take the spoon and add ginger on top of it. It's going to cause irritations and cause relaxation of the LOS. If that is causing harm, you stop doing that. don't do it. I understand it's tasty and will also fall under non-pharmacological interventions. So you can have anti-reflux surgeries or using endoscopic approach to try and heal some of the wounds. So nasal fundoplication surgery is an example of the surgeries that you can do. So in this case, we are talking about an incompetent LOS. The LOS is incompetent such that it is always in a relaxed mood. Now, we want to improve the competency. Look at the name very well. Fundoplication. It means there is fundus. We are going to do something to the fundus of the stomach. So fundus involvement. So you can see the starting point. This is the stomach. This is the stomach. Up here is the fundus. So during the surgery, they are now going to wrap the fundus around the LOS. The LOS is here. So to strengthen the LOS, they are now going to wrap the fundus around the LOS so that they can increase the tightness of the LOS. So you can see that the fundus is being pulled. And finally, you see that it has been wrapped around the LOS, and that can increase the competency of the LOS. This is one of the surgeries that can be done to improve LOS competency and therefore help to minimize or avoid the signs and symptoms of GERD. Any queries before we hit on your domain, that is pharmacological interventions? Any queries? Any queries? All right, let's look at pharmacological strategies. You guys, you are pharmacologists. So this one is just a brief pharmacology about the various classes of medicines that are used in the management. And they're almost the same as what we discussed under this. So you can see that we are trying to use drugs here to improve esophageal clearance so that the moment the refluxate comes into contact here, quickly we wash it, we clear it. For example, by improving peristalsis. The peristaltic movement alone can wash the content down to avoid GERD. So drugs like bethanicol and cisapride. Unfortunately, cisapride was withdrawn in the 2000s. Why? Because it was causing a lot of arrhythmias. So cisapride on the Ghanaian market, you won't get it. It has been withdrawn. Pharmacovigilance. You did this, pharmacovigilance. So these are some of the advantages of pharmacovigilance. You raise signals, you investigate, you find out that, yes, it is caused by the drug. Depending on the severity, it will raise some regulatory actions, and that could be either withdrawal of the drug from the market or suspension or whatever. Unfortunately for cisapride on the Ghanaian market, you can't joke with arrhythmias, of course. It can kill. So cisapride is no more. Then we can look at agents that improve gastric emptying. Metoclopramide is available and we use it, both the oral forms and the injectables. It's a prokinetic and it can enhance forward peristalsis. Cisapride again is not available on the market. Then we can look at agents that can improve mucosal resistance, acting like mucus to form a barrier to be able to protect the lining of the esophagus. So we can use alginic acid sucralfate. These agents can form a barrier and protect the lining from the direct contact of the harmful or the aggressive factors. We have agents that can also improve LOS pressure. They can improve the contraction of the LOS. Bethanicol, metoclopramide are there to help us. They can improve the way the LOS can contract to close so that substances will not move upward. Then, of course, we target the concentration of the refluxate, gastric acid. So agents that can minimize gastric acid production and release, agents that can neutralize the released gastric acid. So we have antacids, acting like bicarbonate. Then we have H2 receptor antagonists and PPIs that will minimize acid release, and therefore overall together they decrease the acidity of the refluxate. In this case, even if this diluted refluxate. So these are the brief pharmacological agent, their classes and the examples that we can use. Let's look at this drug, baclofen. Baclofen, we have not mentioned it, so let's tackle it. So baclofen, of course, is a GABA B agonist, and it reduces the transient relaxation. Remember, we implicated transient relaxation of the LOS as part of the causes of GERD. So baclofen can prevent that and avoid acid reflux. There's evidence backing it that when you take it, it helps to improve signs and symptoms. Unfortunately, baclofen comes with a lot of side effects, ranging from dizziness to somnolence and constipation. This has resulted in its limited use in the management of GERD, but it has that potential to avoid transient LOS relaxation. Now, let's look at what the American College of Gastroenterology they are saying in terms of pharmacotherapy. What are they recommending? Any queries before we continue? Any queries? Class captain, are we good? Can you hear me? Am I still online?
Yes, please, sir. We can hear you.
All right. All right. So they are even giving lifestyle modifications, and it's not different from what we have discussed so far. So they are saying eat early before you go to bed, 2 to 3 hours at least before you go to bed. If you are overweight or obese, please find some means to reduce your weight. Reduce your weight. Do exercise. Stop eating at night. You see your belly protruding. It won't help you. You get GERD. Avoid smoking. Avoid. And any other tobacco product. Stop taking them. Shisha. Those things. Please stop. If you are on any food or something that can serve as a trigger factor, stay away. And of course, if you already have some of these problems or not, buy some pillows. Don't be sleeping flat. Buy some pillows so that you can elevate your head. By way of your posture, it's not easy for the regurgitation to occur if the esophagus is always above the stomach. So some of these things are recommended as lifestyle modifications by the American College of Gastroenterology. So what are they recommending in terms of drug therapy? To minimize acid secretion, of course, PPIs are always superior, except at times nighttime acid secretions. You put your patient on PPIs, you realize that they are okay during morning and daytime, but night times they are not okay. Some clinicians can prescribe H2 receptor antagonists in addition. So if you see a prescription like that, don't just jump into conclusion and say there is a care issue. Some clinicians can combine in one patient, in one regimen, PPI, then they repeat H2 receptor antagonists. You need to ask, probe further. Probably the patient has been on PPIs but still complain of nighttime symptoms. PPIs, they do well, but nighttime acid secretions, they are not able to cover well as compared to H2 receptor antagonists. So some clinicians may add H2 receptor antagonists for nighttime issues. Then you take your PPI for morning or daytime issues. But in GERD, of course, all in all, if you are talking about superiority, PPIs are better, and therefore they are preferred referred. Of course, we take them on empty stomach so that they can be activated. That one, you know. I sent you, in addition to the slides, some other information, plenty, that you are supposed to read. The pharmacology of these PPIs and H2 receptor antagonist. Find time and read it. That word for read it. Now, if you're on PPI, as we described for the 8 weeks trial, and you become better, please try and then stop taking it. Try and stop taking it. But of course, if you're on it, you need to comply. You need to comply. Now, GERD patients should discontinue PPIs when they are relieved from erosive esophagitis. Barrett's esophagus symptoms. You are okay now, so why are you still on it? So don't keep on taking it. Some people will not go back for a review and see the doctor. They think that henceforth they are going to take it lifelong. No, they always go to the pharmacy and then buy it. Please, that's not how you take drugs. If you're on PPIs, make sure that you take the lowest effective dose. Of course, that is key. If 20 milligram can do the job, why are you taking 40 milligram? Remember, these drugs also comes with side effects. The higher the dose, the higher the possibility of the side effects. Now, if you put patients on PPIs and they don't respond, please don't waste your time that you want to add other drugs to it. I repeat, if you put any patient on PPIs, forget management, and they don't respond, don't waste your time thinking that you can add baclofen, you can add sucralfate, you can add metoclopramide, and it won't work. So don't waste your time adding other drugs to PPIs. If you put somebody on PPIs to manage GERD and the patient doesn't respond, it won't work. It won't work. Now, some individuals with severe forms of esophagitis, Los Angeles grade C and D, may have to be on PPIs indefinitely. Because the moment they abort, the problems comes back. In that case, please, they may have to be on it indefinitely. Now, you don't normally use baclofen. You only use baclofen when objectively you have confirmed that the person truly has GERD. What are these objective tests? We are talking about endoscopy and or the ambulatory pH monitoring. So you need to confirm before you even decide that you want to put somebody on baclofen. You should have an objective evidence that somebody is having GERD. You don't just base on signs and symptoms, then you introduce GERD. For PPIs, you can base on signs and symptoms and do an 8 weeks to 12 weeks trial. But baclofen, because of the limitation, side effect, don't just start baclofen because of subjective data. Please, before you initiate baclofen, make sure you have objectively diagnosed the condition. Now, considering prokinetics like metoclopramide is not recommended unless the patient is confirmed to have gastroparesis. Prokinetics enhance forward peristalsis. In GERD management, please don't do it unless the patient is confirmed to have what? Gastroparesis. So you'll be expecting this in diabetes patients, diabetes type 2, with a lot of complications. So by way of their neuropathy, they may present with gastroparesis, and that may contribute to their GERD. In these individuals, yes, you are good to go. You can do a prokinetic like metoclopramide in them. Also, barriers like sucralfate are also not recommended except in pregnancy. So in pregnant women, you may do sucralfate. In fact, it is second line agent after lifestyle modifications, together with alginase and antacids. Those are second line after lifestyle modification in pregnancy. So those that behave like mucus, yes, they are recommended in pregnancy. They are recommended. On-demand or intermittent PPI therapies for heartburn symptoms control is recommended in patients with non-erosive refluxes. So those with endoscopic negative reflux disease, you can give intermittent or on-demand PPIs to manage them. They complain of the signs and symptoms. You go in there, fine. The endoscopy reveals very fine linings, no issue. Yet they are suffering. You can offer them some intermittent PPIs to control their signs and symptoms. All right.
For my hand is up.
All right.
Yes, for so this is propane. I hope you are doing well.
Hey. Senior. All right.
I salute. Proceed.
Hey, what are you doing here?
I was passing through.
Okay.
All the best.
Yeah.
We'll talk again.
Thank you. Hey, doctor. Okay, I'll call you. All right. Okay. All right. So let's look at pregnant women. As I said, pregnancy alone is a high risk factor for GERD. So you see that you ladies, around this time, you are not complaining of any GERD. The moment we give you a heavy shot, then you become pregnant. Then you start worrying us. So pregnant women, they are difficult. All these things will be worrying them. So it's not their fault. Heartburn. Why? Because the developing fetus is increasing abdominal pressure. Quickly, I think we implicated estrogen as a drug that contributes to LOS issues. Where is it? Yes, you can see. Progesterone and estrogen, they decrease lower esophageal sphincter tone. So during pregnancy, naturally, it is these hormones that will be maintaining your pregnancy, and you have them in high levels, plus the increasing abdominal pressure from the developing fetus. So you have at least two independent risk factors here. Some people, after their third month, can buy a whole lot of things. If they have iron deficiency anemia, then pica can even cause anything. They would even tell you that they prefer chewing this fatty meal, this fatty meat. How do you call it? The one we used to prepare awamu. How do you call it? Class captain. Beef. Yes. The salty one, beef. So fat, a lot of milk, progesterone, estrogen, developing fetus. So high risk. So they are always complaining of heartburns. Yes. So then, of course, it begins with lifestyle modifications in pregnancy. So stop taking fatty meals. You have to do exercise a bit. You may even be an overweight or obese person already. Do exercise. Pregnancy does not preclude exercise. Do it. Do exercise to reduce your weight. As for the hormones, you can't do anything about them because you need them to maintain the pregnancy. But other contributing factors that are modifiable, please control them. If those modifications doesn't help, then second line agent that you call in to come and help will be the antacids. I will not recommend calcium containing because of the rebound acid secretion, as discussed during our PUD class. Aluminium combined with magnesium so that they cancel out the constipation and then the diarrhea problems. Then alginates or sucralfate that can work just like mucus. These are the agents that are recommended as second line after your lifestyle modifications. If these two doesn't help, then you can go to H2 receptor antagonists or PPIs. They come with pregnancy risk, but at least it's not that harmful. Except omeprazole, all PPIs and all H2 receptor antagonists are FDA pregnancy category B. Omeprazole is FDA category C. What do I mean by FDA category B and FDA category C in terms of safety of medicines in pregnancy? So these are that. I'm not going to read everything. So we said H2 receptor antagonists and PPIs, except omeprazole, are all category B. So when we say a drug is classified as pregnancy category B, it means that animal studies have revealed no evidence of harm to the fetus. So on those drugs, we don't have any animal research giving us any clue of harm. However, there are no adequate and well-controlled studies in pregnant women. Of course, what we see in animal studies may not always be the case in humans. So once you do it in animals, you have to confirm in animal and humans. We are a bit different metabolic pathways, different genetic makeup. And therefore, if a drug is not seen to have caused harm in animals, it doesn't mean that automatically it cannot cause harm in humans. All right. Or animal studies have been conducted and there are no adequate and well-controlled studies in pregnant women. So fairly good. You can take a drug that is classified as pregnancy category B and you are pregnant. Yes. The risk is that we don't have enough evidence in pregnant human beings. Then omeprazole. Animal studies have shown an adverse effect, danger, and there are no adequate and well-controlled studies in pregnant women. Or no animal studies have been conducted, and there are no adequate and well-controlled studies in pregnant women. Risky as compared to those classified under B. Read the rest on your own. These are just classification of medicines. When somebody is pregnant, it will help you to know if the drug is classified like X, then you know that is a no-go area when you are pregnant. You can't go there because there is evidence that if you are pregnant and you take, you can be in trouble. Now, let's look at when you come, you have GERD, but it is not relating to the esophagus. The problem is there, but it is an extra esophageal GERD symptoms. So like respiratory issues, laryngeal issues, pharyngeal issues. So evaluate for non-GERD causes in patients with possible extra esophageal manifestations before you implicate GERD. It's not all the time that GERD will be the bad boy. You will have to do proper evaluations. So patients with extra esophageal GERD, but without, yeah, I'm coming. Yeah, go there and wash. Go back. Hello. Hello.
Hello, sir.
Okay, please, sorry for that. It's this small girl who has been worrying me. So patient with extra esophageal manifestations of GERD, but without typical GERD symptoms. That is this text for evaluation for PPI therapy. So those individuals, it's very difficult to determine whether it is GERD or not. So you should be able to take them through the monitoring strategies. So long-term monitoring, one day you catch them. You will catch them that it is actually the regurgitation that is causing that. So in patients with both extraesophageal and typical GERD, of course, extraesophageal and typical GERD, then typical GERD take precedence. Straight away, you can do your 8 weeks to 12 weeks trial of PPIs and see if the patient will respond or not. If the patient responds, both extra and typical esophageal problems will subside. Hello, is there a question? Now, obviously, extra esophageal problems doesn't relate to the esophagus. So why do you want to do endoscopy to confirm this? The problem is within the respiratory system, the pharynx, the larynx. So it's a total waste of time for you to do what? Endoscopy, upper GI endoscopy to confirm extra esophageal problems. Please don't do that. In patients treated for extra esophageal reflux disease, surgical or endoscopic anti-reflux procedures are only recommended if objectively you have been able to confirm that there is an evidence of reflux. Of course, surgery is no joke. So you can't base as in your evidence on subjective data and go and then send somebody to the theater that you are taking him through surgical procedures because of GERD. No. Before you do that, you need a very strong evidence to do that. Now, what happens to refractory GERD? Of course, before you say that somebody's GERD is refractory to normal therapy, you need to optimize. At times, it is from the clinical team. You are not managing the team well. The person is not taking the required PPI. The person is not doing the required lifestyle modifications. And therefore, that's why the person is not responding to treatment. It's not a true refractory GERD. So before you say that somebody's GERD is refractory, make sure that you have optimized therapy, both pharmacological and non-pharmacological. And if it is true that the person's GERD is refractory, do your monitoring without, we have mentioned this already, do the monitoring without a PPI. This can help you expose the person. So with PPI, you suppress acid secretion, the signs and symptoms subside. But without PPI, the person is not having any defense, the person is exposed. So do it and then do your monitoring parameters to confirm. With that, then you may, because drugs are not working, then you may go in for non-drug procedures like surgery, either the incisionless ones or the ones that they open you up, laparotomy. So don't just put somebody under surgery, just confirm before you do it. Confirm before you do. So let's look at some of the surgical myths. Surgical means, so this will be part of the non-pharmacological strategy. So when do we go in for surgery? Obviously, refractory cases, and severe forms, refractory stroke severe forms. So for example, based on the Los Angeles classifications, if it comes out at severe esophagitis, that is class C and D, any of them, that could be an indication. Hiatal hernia, you need repair. You need to repair the herniation. So if it is large enough, once it is large enough, it means that it is always exposing the patient to regurgitation. So you need to strengthen it and then close the gap a bit. Then persistent, troublesome GERD symptoms. So you see, all these are severities. Anything that can contribute to severity and refract, it means that drugs will not be able to help, and therefore surgeries must come in. So examples include transoral incisionless fundoplication. So just as we witnessed for the laparoscopic one, laparotomy, the first one that we witnessed, that they wrapped the fundus around the LOS. That one, they will open you up. So that one is by laparotomy. So by way of improvement, they now have another procedure that they will do almost the same thing, but without cutting you open. So they pass a certain device, medical or surgical device in there, and then perform a similar thing wrapping the fundus around without cutting you open. It has been found to help a lot. We can also do radio frequency and deliver radio frequency energy. So the machine is called a stretcher. So when they go there into the energy, what this will do is to make sure that there will be remodeling within the LOS, and it will improve or increase the muscle size and the muscle tone. So introduction of this radio energy frequency will make sure that the tissues of the LOS will remodel, become bigger than it is, and that can help improve its competency. This is what we called the radio frequency energy strategy. It is called strata. That is what they do. They can also pass in there and then wrap around the LOS with some magnetic beads, like the beads that you put around your ankle or your wrist. So it's in the form of magnet. So they go and then wrap it, and that will make sure that with its magnetic nature is able to improve the contractions and the realization. So that magnetic beads is able to sense when food is coming so that it relaxes. And when the food passes, it contracts on, or it puts pressure on the LOX to contract. So you wrap these magnetic beads around the LOS, and it will help improve contractions and relaxation as and when food passes through and leaves. If it's coming, the magnetic beads wrapped around the LOS will relax, opening the LOS for the food or drink to pass. The moment it passes, it will contract, closing the LOS so that we don't get regurgitation. Then we have Roux-en-Y gastric bypass. Roux-en-Y gastric bypass. This thing, I'm even afraid. They do this a lot in those who are obese. Why? Because this is how it looks like. It's an attempt to reduce the size of your stomach. So what they do is that, as you can see here, this naturally is your whole stomach, but you can see they've cut a huge portion, cutting the fundus off the corpus, the antrum. So what is left is only the fundus connected to the LOS and the esophagus. Then they cut your small intestines. They cut your small intestines. Then they join the small intestines with the fundus. And the remaining other part is also joined to the rest of the small intestine. So now they have reduced the size of your stomach to this size, such that the slightest food that you eat, in no time you are full. And automatically you are forced not to take excess meal. Already you are an obese person. And that helps in managing obesity, and also has been found to contribute to lowering or preventing the signs and symptoms of GERD. This is done. I'm sure the general surgery people over here can do it. So these are some of the surgical procedures. Roux-en-Y, magnetic sphincter augmentation, that is the magnetic beads wrap around. Then introducing radio frequency energy that modifies the structure of the muscles of the LOS, and that goes remodeling, becoming much more competent than it is. And remember the laparotomy one, the first one, that is nasal fundoplasty, the one that they cut you open, they wrap your fundus around the LOS, making it tight so that it will not allow food substances or the stomach content to be regurgitated. Ladies and gentlemen, this marks the end of our discussion on GERD. If you have any questions, the floor is open. Any queries? Any contributions? Any concerns? Yeah, hello?
Yes, please, I want to understand what about sucralfate is making not use it unless it's a pregnant person?
You see, in fact, when it comes to GERD, all those pharmacological interventions, apart from PPIs, are not that effective. That is why they even said, if you are on a PPI and the patient doesn't respond, forget. You get it. But looking at the safety, because those ones normally comes with less side effects. And in terms of their classification in pregnancy, they are better. If not A, then they are B. So sucralfate and arginate, in that case, yes, if you use them, then they may help. But even with that, we don't want to risk putting the patient on. That's why PPIs and H receptor antagonists are like third line in pregnancy. It's all about safety. You are looking at the fetus, you are looking at the pregnant woman. So anything that is not pregnancy category A, we just don't want to recommend it in pregnancy. You first look at safety options, those that are very safe, before you consider less safer options. And if they can work for you, why not in pregnancy? But in general, they are not as effective as PPIs. Please, are you okay? But it
They are
has
not
now come
as
to the
effective
point.
as
Yeah,
PPIs.
no,
So I
that's
need
why
some
that recommendation
clarity.
is. They can
So is
help,
it that we
but not as effective.
okay, meaning that we can use them in GERD, but they are not as effective as PPIs?
But you need to do benefit risk ratio in pregnancy in particular. You get it? So if omeprazole can work, but it
Your line
comes with
broke.
high risk, yes, but they are riskier as compared to. Hello, your line has been breaking. Please come again.
Yeah, I mentioned that your line was breaking off a bit. So if you
Okay.
could please come again with the explanation.
So now the thing is, PPIs are the most effective, but in pregnancy, a bit risky as compared to sucralfate and arginate. In pregnancy, you can't risk safety issues. You can't risk. So yes, PPIs are effective, better than those that will work just like mucus. But because of safety issues, let's throw in the less effective but more safer option. We even said that lifestyle modifications without any drug may even help. You see the thing? So if you are going for any drug again, you look at safety first in pregnancy. Fine, efficacy too is very important, but safety first. You can't give a drug to a pregnant problem is solved, but you cause congenital anomaly. You cause what they call serious adverse drug reactions. No, that's a no-no. That is why per the authority, that is the recommendations by the guidelines, they've relegated these drugs, H2 receptor antagonists and PPIs, as third line. In that case, we refer to it as conditional recommendations. You use them only when lifestyle modifications or sucralfate, arginate, and the rest, and the antacids will not work. So it's a conditional recommendation, obviously based on safety. Are you okay?
Pam, I understand what you said, though, but what you told us was that sucralfate is good unless in pregnancy. So I'm not talking about pregnant people. I'm asking about the use of sucralfate in itself, especially if you've ascertained that the pathophysiology of the GERD is mucosa resistant. Can we use sucralfate? That's my question.
You can use, but it's not as effective as PPI. So if
Okay.
the person is not pregnant, go for your PPI. Do you get it?
Yes,
If the
thank you.
person is not pregnant, you go for PPI. If you go for PPI, that's me saying in person. I ended up saying inpatient because I was tired. So her concern and plea. So her concern and plea was that maybe when it gets to the middle, if when we do like 1.5 hours, we can have like 5 minutes break, refresh, and then come back after 5 minutes or 10 minutes and continue. And I think it's a laudable idea. I don't know if it's okay with you. I don't know. So if that is fine, then class captain, please, when I'm heated and I'm cruising, at times I forget to even stop. So anytime that we start and we get to 1.5 hours, please stop me. Let's relax for like 5-10 minutes. Come back and continue. First half, second half, 10 minutes break. Class captain, I hope that is okay. I don't know your take on this. If it's okay, those on the call, please, is that okay? Is it okay for us to have that
Yes,
break?
please. It's very okay with
Yes,
us.
please.
Yes,
Yes,
please.
please.
Yes,
Okay.
please.
All right.
Yes,
No,
please.
please, no.
Exactly.
And I who says they know.
Yes, please, please. Yes, please.
All right.
Yes, please.
Okay.
Yes, please.
All right. So
Yes,
henceforth,
please.
Yes,
please, class
please.
captain, yes, try and then prompt me once we do 1.5 hours. Just make the announcement so that just ring the bell. So as a class captain, you are the is it bell boy as well? So you stop at it's 1 hour 30 minutes break time. We go off for like 10 minutes. We come back and continue. All right. So any other concerns? Next week Saturday we continue with our anemias. We could
Please, the slides. You have
didn't
not sent them.
finish the sickle cell disease. We will continue on after. Then we hit on GCSPD induced autoimmune hemolytic anemias. It's because we're able to finish. Because I want you to be writing your own notes as well. So that when you get, because there may be certain things that may not be in the slides. Maybe you'll be discussing it. So I want you to keep on putting down all those things. Then you get the slides and add. So as for the anemia, unless we are done, then I'll send it to you. But I'm going to send this one since we are done. Please,
Please,
are
I
we
have a
okay?
question. Okay, so you said prokinetic use in GERD is only indicated when there is a case of gastroparesis, right? And
Yes,
you also
please.
said that metal can be used to increase the activity of LOS. So in what
Yeah.
case or when do you or how do you shift the effect of metro more towards the increasing activity of LOS than towards the prokinetic side?
Okay. So ideally, you see, every drug or some drugs may have multiple mechanisms, but as always, one of them will stand out as the principal mechanism. In the case of prokinetics, yes, the principal pathway or the principal mechanism is the prokinetic effect. Though their effect on other receptors may give rise to issues here like the increasing the LOS sphincter, but that may not be that significant. So in GERD, in fact, we actually base their effect, their prokinetic effect. It is based on that prokinetic effect that we use them. As for increasing LOS, fine. Based on their pharmacology, they can also give us that. But in true practice, when somebody presents with gastroparesis, then you consider metoclopramide as an example of the prokinetics. Hardly would you normally choose prokinetics for increasing LOS sphincter tone. No, normally it's not done, but at least once you give it for prokinetic property, of course, it will also add a little bit of improving LOS sphincter. In fact, when the LOS loses its integrity, then it's becoming serious, especially when it relaxes too much. If you are not lucky, it's one of those surgical interventions that can help you. Drug intervention may not be able to help you. Please, are you okay? So, key prokinetic property, principal in GERD. Are you okay?
So by this you mean there's no way you can increase the tone of the sphincter in isolation using drugs.
That's an example, but it's not the principal pathway. You get it? It's not. If your LOS is truly relaxed and is incompetent, fine, drugs may do something, but I tell you, you may have to go for any of those surgical interventions. Are you okay?
Yes, please. Thank you very much.
All right. All right. Okay. Any other questions, please? If not,
Please, I have a
hello?
question.
Yeah, hello.
Hello. Yeah, please, you talked about ruling out heart disease in chest pain as part of the AC recommendation. Please, how do you do that before doing the
That's the question I asked
CBT?
you. You guys failed to answer. So then answer. You have done ischemic heart disease. I asked you that question. You decided not to answer. Because I know you've worked on ischemic heart disease, angina, and all those things. MI, STEMI, and STEMI, unstable angina. You've done this. That's why I asked you, but nobody answered. I think one person came out and then he started mentioning something about chemistry with troponins and those things. I proved further, but he didn't continue. This is a question that I know you have the answers. You are just refusing not to, as in, say them. So please, please help us. How do you rule out or rule in ischemic heart disease? I even said if you are asked to choose 3 labs, that can help you confirm. How do you go about it? Prophet Takra will not be happy because I think that will be his first topic. If he asks you about this, and you kindly tell me. Hello.
Yeah, we can hear you.
I'm not trying to ask you to even give us how you differentiate STEMI from STEM. All in one, like all ischemic heart diseases. What are some of the labs that you use to confirm or rule out? And the rationale, why those labs? Very simple. Scott, are you there?
Yes, sir.
Scott, let's hear from you.
Uh, okay. So let me take the troponin. There's the one. The troponins. So the troponins, they lie within the cardiac myocyte. So when there is like an injury to the cardiac myocyte, they are then released into the bloodstream. So you can do the troponin test to check the levels of troponins within the blood to confirm
So
that
that means that in ischemic heart disease,
there
there
is
will
an
be.
yes.
All right. Okay. What else?
Can also do the ECG,
12,
which will help
12
you
lead
differentiate between
ECG.
the STEMI.
12 lead ECG.
The 12 lead ECG,
Okay. Why?
which so I have differentiate between the STEMI and the STEMI.
No. So why are you doing ECG? Why? What will the ECG tell you? Looking
Oh,
at
well,
the condition that we are talking about.
so it will give me a fair idea of the rhythm, the rhythm of the heart, the various rhythms, whether there's a defect, there's misfiring somewhere.
Scott, we are talking about ischemic heart disease,
Hey,
not arrhythmias.
sorry.
Ischemic heart disease. What are some of the etiologies? There could be thrombus formation.
Thrombus
There
formation,
could be
blockage in the
embolus.
ECG.
Yeah, so blockade. So can't the ECG connect you to possible
Yes.
blockade, occlusion? Yes.
Yes.
So you can do that. So my lady, the one who asks about how I know you know this one, you know. As for MI and those things, you have been presenting on them every now and then. Just that you just decided not to tell us. So yes, these are some of the things you need to do to rule out the presence of MI before you go ahead and then you do. So these ones, ECG, troponins, what have you, you do them. All right. Any other questions? All right. So next week, Saturday,
No,
we'll continue.
please.
All right. We will continue with our combined class on anemia. When we come back again on Sunday we will do vomiting. Yeah. We will do nausea and vomiting. Another brief topic, so we can finish on that same day. Then afterwards, we can consider other topics. I think this will be my GIT topics. Dr. Takra will add the inflammatory bowel diseases and other things. So when he comes, he will also tackle the remaining GI conditions. Then I'll have to switch to maybe respiratory and then try and do asthma or something. Yes. But Saturdays, we keep on doing our anemia till we are done. When we are done, we will start another combined class on hypertension. When we are done, then we decouple. Then we'll be doing our own things both on Saturdays and until Prophet Takra comes in and take the Sunday evening class with you. As for Saturdays there, I'll be with you till. All right. Thank you very much for the audience. We meet same time next week. Have a nice evening. I'm sending you the files on the page.